This video is just theoretical. What this is about is one of the things I do is I am a neuroradiologist. I used to run a spinal injection clinic in a previous life, do tons of spine biopsies, epidural steroids, selective nerve root blocks, discography, all that stuff. Anyways, I've written 2 books on spine. I'm going to talk to you a little bit about what I see is you could use the lumbar spine plane film as a screening method for disease. Now, this is not official. This is just an idea that I've thought of. I have not officially done a big research study on this. I just know from clinical experience from having looked at, over 100,000 of these things. This is what you see. This is a relatively normal patient. What I'm saying is I can judge the patient's age pretty accurately by looking at their lumbar spine plane film. So here's the sacrum. It's all one tubular piece, kind of shaped like a cone. And then when you have a rectangular vertebral body, the first rectangular one is L5, L4, L3, L2, L1. That means lumbar 1, 2, 3, 4, 5. Okay, here you just see a little bone spur, a little osteophyte is what the bone spur is. But these disc space heights are relatively intact. Vertebral body heights are intact. Okay, the end plates are intact. Okay, then let me show you what film I was covering up initially. This patient over here has a calcifications of the aorta from atherosclerosis. They got a little L5S1 disc space narrowing. So this is a patient further down the path. And if they've got atherosclerosis in their abdominal aorta, it's a great bet they've got pretty significant coronary artery atherosclerosis in their heart. Okay, and they're headed towards a rapidly progressive worsening of their spine. So what I'm saying is these are predictors of the age of the patient. I'm just going to show you how I identify the findings, then I'll show you the classification system that I made up. Here's the appearance on a CT scan, a lateral view with the findings labeled. Aorta ASP is atherosclerotic plaques, calcified atherosclerotic plaques. These are the anterior bridging osteophytes. When you have more of them, we'll call that DISH, diffuse idiopathic skeletal hyperostosis. You can see the disc space here has gas, so that's gaseous DDD, degenerative disc disease. Okay, you can see the posterior disc space is calcified, which would include the posterior longitudinal ligament. That's called OPLL, ossification of the posterior longitudinal ligament. You can see you've pretty much lost the entire disc space height, so this would be severe disc space narrowing. You're probably headed towards IBF, interbody fusion of the vertebral bodies. So this is a very advanced spine disease. This would be like somebody pretty typical for a guy over 80s, but if somebody younger, then they would have accelerated degenerative disc disease of the spine. But it's routine for guys over 80 to look like this. Many people in their 70s look like this, and even some unfortunate people in their 60s look like this. Okay, and this is a terrible looking spine. This person's not too functional. Okay, now here's some other findings we often see in the spine. This right here is when there's offset, slippage. You name it relative to the vertebral body above compared to the one below. So this would be anterolithiasis, slippage anterior, posterior vertebral body end plate contour line relative to this one. It's slipped forward. You can also see this disc space is narrow. The disc space should get bigger as they go down. So you would have moderate disc space narrowing with grade 1-2 anterolithiasis. Over here, the upper vertebral body is displaced posterior relative to the one below it. So this is called retrolithiasis. And there's only mild disc space narrowing. You've got gas formation within the disc space here, so this is gaseous disc degeneration with severe disc space narrowing. You've also got retrolithiasis here. And you've got some calcification. That's a type of osteophyte where it's more vertical. We call that a syndesmophyte, but it's equivalent to an osteophyte. So these are signs of progressively worsening degenerative disc disease. So this would be much worse than this because this is severe disc space narrowing. This is only sort of mild to moderate. Okay. And now here's a patient again with severe degenerative disc disease of the spine. You can see there's severe disc space narrowing, virtually complete, with some early evidence of interbody fusion, bridging osteophytes. You're headed on that path towards DISH, diffuse idiopathic skeletal hyperostosis, bridging osteophyte, bridging osteophyte, bridging osteophytes. They're going to bridge together and fuse, suggesting you've got abnormal motion at this disc space level, such that the vertebra wants to stabilize that abnormal motion by fusing the bones. Okay, you got a little bit of retrolisthesis here, a posterior bone spur. So you're heading into OPLL, ossification of the posterior longitudinal ligament. Sometimes the posterior spinous processes will start to rub against each other and get erosions and sclerosis. That's called Bostrup's disease. Anyways, all of these things are indicators of where the patient's at. Again, this would be a typical looking spine plus 80, very common in the 70s, a lousy looking spine for a 60-something, and a really lousy looking spine for a 50-something. But again, I can usually tell how old the patients are. So I showed you all those findings. Actually, I'll show you one more. Oh, that was kind of the same thing, I think. Yeah, so let me show you. Here's what degenerative scoliosis looks like. So scoliosis is curvature of the spine. Normally it should be totally straight. So you can see it's curving here towards the right. So you could call that dextro. Dextro means right scoliosis, or I would just say, moderate lumbar scoliosis, convex to the right. And then, I figured out the mechanism of this is that you have the lumbar arteries come off mid-height of the vertebra. Red is for the normal ones. But let's say you have an occlusion of the lumbar artery. They run at the mid-vertebral body height. All these little red dots are normal. The blue dots, let's just call those occluded, thrombosed lumbar arteries. And so once they're thrombosed, that means they don't provide good blood supply to this disc. And the disc can just fail. It'll crack, it'll dry out. It'll be dry out as desiccated disc. This would be gaseous disc degeneration, gaseous disc degeneration. You can see there's asymmetric disc-based narrowing, much worse on this side where the lumbar artery is occluded. So that's the mechanism of asymmetric degenerative disc narrowing due to ischemia through occlusion of the same-sided ipsilateral lumbar artery. Okay, that's what it looks like. Okay, so this is a lousy looking spine, typical in a 70-something-year-old or an 80-something-year-old person. In a younger person, that would be much more accelerated disease. Okay, here's just a plain film appearance of it. That last one was a CT scan. So on a plain film, let me get myself out of the way here. Okay, you can see there's gaseous disc degeneration in here. You can see asymmetric narrowing of the disc. It's more narrow on this side, the patient's left, than on the patient's right. Apex of the curvature is towards the patient's right. Okay. You can see these bridging osteophytes. So that's also disc, diffuse idiopathic skeletal hyperostosis, and they're forming in an attempt to fuse the vertebrae so that you won't have abnormal motion. If the patient's undergone surgery, a laminectomy, you can see the spinous process is off there. The spine's starting to rotate. There's a component of rotatory scoliosis. Okay, so this is what I meant by a classification system, that I can just look at the spine. I don't need to know anything about the patient, and I can pretty accurately judge their age. Less than 30, it's usually going to be normal. 30 to 40, I'll have about one disc-based narrowing. I abbreviate it DSN. DDD is degenerative disc disease. Okay, I usually see like one, starting to form osteophyte. You're starting to get the earliest manifestation of degenerative disc disease. Usually the end plates are clean. Schmorl's node is when a disc herniates into the adjacent vertebral body. We call it a Schmorl's node. HMP is herniated nucleus pulposus, meaning the center of the disc. No aortic calcification is 30 to 40. That'd be a typical looking 30 to 40-year-old. 40 to 50, start getting a couple discs narrowed. Often you'll have some gaseous disc degeneration, some erosions of those end plates, early calcification of the aorta. 50 to 60 years old, more disc-based narrowings, more severe disc-based narrowings, more bridging osteophytes, usually one gaseous disc degeneration, more aortic calcifications, indicating progression of coronary artery disease in those calcifications. 60 to 70, typically 3 or more discs are narrowed, often moderate to severe gaseous disc degeneration. Usually I'll see dish in most patients, moderate to severe aortic calcifications. Typical patient, they all have the same disease. They all have hypertension and prediabetes, diabetes leading to atherosclerosis, which gives you those aortic calcifications, ischemia of the spine, lack of blood flow to the spine. They usually got coronary artery disease, cerebrovascular disease early, lower extremity peripheral arterial disease early, aortic calcifications, early but moving into moderate here. And then as they just get older, you just get more and more of the same. So what I'm saying is I'm not a big fan of coronary artery calcium screening. I know that's a popular thing. My attitude is, you got it. Just go low-fat vegan is what a smart person would do. And on top of it, once you start doing a CAT scan of the chest, you're going to potentially see borderline or enlarged lymph nodes. You're going to potentially see lung nodules, and you're going to get stuck into follow-up for all that, which is kind of a pain in the butt, potentially quite expensive. You already know if you're eating a high-fat diet, you got coronary artery atherosclerosis. You can check your total cholesterol, because the more things you take a picture of, the more normal variants you're going to find, the more incidentalomas you're going to find, the more likely you're going to get stuck into more extensive follow-up. So anyways, what I'm saying is, again, this is not official. This is just my own personal idea, but based on a lot of experience, I can tell you this is pretty much what I see. Anyways, hope that was useful, interesting to you.